Good afternoon. My name is Marie Rienzo, and I want to welcome you to the NIH Office of Disease Prevention's Mind the Gap webinar series. This series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods and to support the development of better methods. Before we begin, I have some housekeeping items. To submit questions during the webinar, there are two options. First, you may submit questions via WebEx by clicking on the question mark in the WebEx toolbar. Please direct your questions to all panelists. Second, you may participate by Twitter and submit questions using the hashtag NIHMTG. At the conclusion of today's talk, we will open the floor to questions that have been submitted via WebEx and Twitter. Lastly, we would appreciate your feedback about today's webinar. Upon closing the WebEx meeting, you will be directed to a website to complete an evaluation. We would appreciate your feedback. It will help us improve this webinar series. At this time, I'd like to introduce Dr. David M. Murray, Associate Director for Prevention and Director of the Office of Disease Prevention.
Thank you, Marie. Today's speaker is Dr. David Hopkins, who's a Medical Office Community Guide branch of the Centers for Disease Control and Prevention. He joined the Community Guide in 1997 and has led systematic reviews of population-based interventions in tobacco prevention and control, in asthma, diabetes, cardiovascular disease prevention, physical activity promotion, and immunizations. He's also worked closely with Community Guide researchers, CDC partners, and members of the Community Preventive Services Task Force on methods for both conducting systematic reviews of public health interventions and prioritizing future Community Guide topic areas and intervention reviews. Dr. Hopkins is coming to us today from Portland, Oregon. It's my pleasure to introduce him to the webinar.
Good afternoon. Thank you for that introduction and the challenging opportunity to summarize 22 years of task force debate in a 40-minute webinar. First, a disclaimer. CDC provides staffing and administrative support for the Community Preventive Services Task Force, but their assessments of the evidence, findings, and recommendations do not necessarily represent the official position of CDC. Here's what I'd like to cover in this webinar. First, to introduce the Community Guide and the Community Preventive Services Task Force and their perspective on an evidence base for public health. I will highlight a few of the systematic review methods used to support task force recommendations and additional findings. I will use a study on inclusion of practice-based evidence to quantify observational study designs in our work. I'll point out a few of the process steps used to conduct systematic reviews of economic evidence and end with a few persistent challenges. It's possible that I will gloss over a couple of the slides in this presentation and identify some judgment tools that we use or that the task force uses, which sort of blur the line between systematic review methods and process guidance for drawing conclusions and recommendations regarding use. The Community Guide, which is primarily now a web resource, houses sets of intervention reviews across a range of public health topics. Our focus is on interventions appropriate for communities and healthcare systems to improve health. Our approach includes, at least initially, a broad consideration of evidence on effectiveness and on other issues important to program planners and decision makers. The reviews produced support the conclusions and findings of the task force. The Community Preventive Services Task Force, which I will now refer to as the task force, is an independent, non-federal volunteer panel of experts recruited from public health and healthcare research and practice. Task force members provide oversight on each systematic review project and guide the development of methods and process steps. As a group, the task force evaluates each completed review, draws conclusions, produces recommendations and additional findings, and highlights evidence gaps, both to promote an agenda for further research and to inform decision making. The current 15 members of the task force are outlined on this slide as well. Since their inception in 1996, the task force has produced systematic reviews in 18 prioritized topic areas, and they have 234 active findings. Every 5 years, the task force engages in a prioritization process for topic area work, both to add new intervention reviews in existing topic areas and to identify new topic areas for exploration as staffing and resources allow. Here's their current unranked priority topic areas, which I've separated to identify the topics that are candidates for expanded work at the top and new areas at the bottom. This diagram identifies a standard set of issues considered in each community guide project. The primary focus is an assessment of the evidence on effectiveness of the intervention for all health or adequately health-linked outcomes. For some interventions, such as policies or programs directed at determinants of health, there may be several different pathways and distinct sets of outcomes. We search for evidence or information on postulated or potential harms, additional benefits, and considerations on implementation. Studies are also organized to examine applicability or generalizability of the evidence to important settings, populations, and intervention characteristics. We examine evidence and information to determine if the intervention is effective or potentially useful in advancing health equity. For prioritized interventions with evidence on effectiveness, the task force may direct a follow-up economic review to assess the evidence on costs, benefits, and comparisons of the two. The ideal goal for the task force is to produce prioritized sets of intervention reviews within each topic. This is the current set for the topic area of health equity, within which the task force approved an initial focus in the subtopic of education programs and policies. A set of intervention reviews such as this set provides options to local decision makers, and in this case span the gamut from pre-K through high school. Task force conclusions range from recommendations for use of an intervention based on strong or sufficient evidence to recommendations against use of the intervention based on strong or sufficient evidence, although we have only produced 2 of those in our history. If the task force finds that the evidence doesn't support a conclusion on effectiveness, they draw an insufficient evidence finding. Frequently, task force reviews and recommendations complement the work of the U.S. Preventive Services Task Force, whose scope includes preventive services and treatments appropriate for primary care or primary care referable settings and providers. Here's an example. The U.S. Preventive Services Task Force recommends that clinicians ask all adults about tobacco use, advise them to stop using tobacco, and provide behavioral interventions and FDA-approved pharmacotherapy to support cessation in adults who use tobacco. The Community Preventive Services Task Force has produced 21 intervention reviews appropriate for communities and healthcare systems in this topic area, and I pulled out 4 with recommendations for use for this example. Of the 4 recommended interventions, the first 2, smoke-free policies and mass media campaigns, are community-level interventions that are effective at reducing tobacco use in the population. And in part, they may do so by increasing demand for clinical cessation services. Provider reminder systems are an effective intervention that a healthcare system may implement to increase identification of patients who smoke. And this can contribute to initiating the U.S. Preventive Services Task Force recommendation for assessment, brief advice, cessation counseling, and medications. Finally, quit lines are effective community-level intervention and provide a community-accessible, referable preventive service that could be used instead of health system-based counseling or in addition to it. The complementary nature of our work is deliberate. It reflects ongoing communication between the 2 task forces and stakeholder interest in increasing the delivery and receipt of recommended preventive services by the U.S. Preventive Services Task Force. Let's turn now to how the community guide and the task force think about public or population health interventions and the range of evidence to be considered in their assessments on effectiveness. Based on their current and future topic areas and the set of education interventions we just went over, should be clear that the task force has a very expansive view of interventions to improve population health. Specific types of interventions range from programs and services to public and health system policies. A scale of implementation for a specific intervention can be very broad, and this can contribute to a highly variable body of evaluation evidence. Both the interventions and the available evaluations can be complicated, including potentially important differences in components of the intervention, settings, target populations, and level of resources used. These differences can affect the effectiveness of the intervention or the findings of the study evaluating the intervention. Task Force considers these to be critical questions for them to attempt to answer using the available evidence. Does the intervention work? How well? Is that impact meaningful? For whom does it work? Under what conditions? Does the intervention have effectiveness or utility for influencing disparities and advancing health equity? What is the cost? Does it provide value? Are there issues related to implementation that would be useful for decision makers to know in advance? In general, the task force takes the position that tentative answers to these questions, based on the available evidence, still provide utility to decision makers and program implementers. Tom Frieden, our former director of CDC, published his framework for public health action in the American Journal of Public Health in 2010. His argument nicely captures the foundational perspective of the task force on the importance of moving public health awareness and action down, in this case, his health impact pyramid. While there are important and effective interventions in all strata of the pyramid, and in fact, Community Guide has looked at interventions in at least 4 of these 5 criteria strata, interventions contributing to healthier social and physical environments and programs and policies influencing determinants of health are likely to have the greatest impact on population health. Incorporating this argument into the mandate of the task force, which is charged with finding and evaluating the available evidence, and you have one rationale for a broad consideration of the evidence. At the top of our pyramid, randomized trials are appropriately both the high standard and a common design for evaluation of intervention effectiveness. At the base of the pyramid, the available evidence may not exclusively consist of, but typically depends on natural experiments, observational designs, and cross-sectional comparisons. Additional reasons for a broad consideration of study designs is to retain evidence or information for assessments of generalizability or applicability across settings, populations, and intervention characteristics. This additional evidence might help the task force to determine components or combinations associated with effectiveness or to document or suggest effect modification. Depending on the intervention and outcomes under review, these decisions come at the cost of including studies with potential additional and important sources of bias, which we may or may not be able to identify and may or may not be able to discount when evaluating the full body of evidence, which consists of a range of different study designs with different strengths and weaknesses. This slide provides one example of the value of retaining observational studies in a community guide review. This is a plot of change in influence of vaccination coverage among workers before and after implementation of a worksite program. Coverage rates for each study are lined up for the years before the on-site program and after the on-site program was implemented. Each study found a relatively stable baseline and a meaningful post-intervention improvement. The team did not identify in the studies and could not generate plausible alternative explanations for this observed effect. And the task force found this evidence to be adequate to support a conclusion and guidance to the field. There are important implications of this willingness to consider a broad range of study designs. As a result, most community guide reviews will retrieve a mixed body of evidence, which requires additional categorization and subset assessments, and those subsets can be based on a very small number of studies. Most reviews will not be good candidates for meta-analyses, at least in whole, and the task force will be faced with having to weigh subsets of the evidence and develop overall determinations on whether the body of evidence indicates a consistent and meaningful effect. Now let's look at some of the process steps built into a typical community guide review to enable an assessment of population-based interventions. There are a couple of process steps in which the community guide reviews differ slightly from reviews produced by other organizations, although the basic approach is similar. Given the breadth of what we're looking at, very different topic areas, very different interventions, we depend on input and oversight from a team, a recruited team of, in most cases, 1 or 2 task force members, 2 to 4 participants from CDC or NIH partners, and 4 to 6 recruited subject matter experts. This group prioritizes the intervention for review within a topic and sets up each specific intervention review. We're going to look at some additional elements in later slides, and this includes study design inclusion decisions, quality assessment, applicability assessment, and task force judgment tables, and those are coming up. We'll start with study design inclusion and exclusion. Now this process step is standard in all systematic reviews. And because we look at a very broad range of topics and a very broad range of different types of intervention, the criteria for inclusion in one community guide review can be very different from another. However, in the simplest terms, most projects will start with the discussion about observational studies are in until the team, and in some cases the task force, argues them out. This slide identifies how we categorize study design suitability for the community guide in the left column, the types of designs included in each category in the middle column, and typical design inclusion deliberations for different types of intervention reviews that we typically engage in on the right. Looking at study design suitability, I'll note that that category includes both randomized trials and controlled before-after designs, although it's quite likely in the next step, which is quality assessment, that studies based on these designs will differ in their quality assessment. Team deliberations are most commonly triggered over inclusion decisions about before-after designs in health system intervention reviews, where they are frequently excluded, and cross-sectional designs for policy interventions, where they are included about half the time. However, it's routine for uncontrolled before-after designs to be part of community program type interventions and policy reviews. Turning now to the assessment of study quality, our process differs somewhat from those of other review organizations such as Cochrane or the ARC U.S. Preventive Services Task Force guidance. Admittedly, our tool, while flexible, is old, and the field, I think, has moved convincingly in a more rigorous direction in the areas that I've underlined on this slide. For example, our quality assessment tool assigns limitations for threats to internal and external validity, although these are primarily focused on the adequacy of the description or reporting. And the field in general favors keeping those separate. Our tool has basic judgment prompts, which teams use as a starting point for a topic and intervention specific set of criteria and decision rules, and that's a common process. We use 2 evaluators for each study. That's a common process. We total up limitations to assign an overall score, and both of those aspects are not used by other organizations. We exclude studies based on total quality limitations, and that's a process that other organizations have moved to more sensitivity analysis as opposed to exclusion. We, like most of the other organizations, set up assessments looking down a body of evidence of included studies for each of our quality categories in order to explore whether the body of included studies have the same recurring quality issue. Here's a slide-by-slide comparison of the quality assessment categories in our evaluation form in the Cochrane risk of bias table. While Cochrane methods are rigorous, clearly described, we'd make use of them if we were looking at randomized controlled trials routinely. Applying this tool to the types of study that the task force routinely considers would not provide much information to distinguish between better and worse, albeit low quality studies. Here's a standard community guide display of a mixed body of evidence with studies categorized by overall quality score and study design suitability. This is not an uncommon distribution for a community-based program type review for the community guide, in which the team retained consideration of observational studies. Synthesis of results here would involve an outcome-by-outcome assessment of study findings with a comparison internally of results from the higher quality evidence, such as the studies of greatest suitability of design here, to the lower quality evidence. Here is an example of a display plot for a non-meta-analysis that is a typical form that is used in community guide reviews. And the example here is from our review of mass media campaigns to reduce tobacco use among youth. Study or study arm effect estimates are plotted usually arranged on some important variable. This display enables several things: an assessment of consistency of intervention effect from the included studies, an assessment of the magnitude of the intervention effect, usually retained in absolute measures, and a comparison of the evidence for the studies of greatest suitability, which are positioned at the top of this display, and least suitability at the bottom. The preferred approach here would have been to have strata-specific median and interquartile intervals as opposed to the overall measure, but this is a common display used in community guide reviews for presentations to the team and to the task force. This is our current evidence assessment table, which the task force uses to organize their consideration of the evidence and to draw a conclusion. I'm not going to go over the details of the table, but I will outline the columns. So there's the final task force rating for the strength of evidence, either for or against use of the intervention in the first column. Then a requirement for, this is just outlining the types of suitability of study designs, moving from strongest to least suitable. Then the required quality of execution, going from good to fair. Required number of studies of that combination in order to use that row for a determination of the strength of evidence. Overall assessment of the distribution of study results for outcomes that are going to be the basis for the task force conclusion on effectiveness, whether it's consistent or not. And the overall assessment of the population health impact based on findings from the studies. Is the impact meaningful in a public health or population health sense? I will point out that the use of this table is to start at the top and work down the table. This approach ensures that consideration of results from the stronger subset of designs are considered first. If you can answer question of effectiveness based on studies of greatest suitability design, has the potential to be a strong body of evidence. If you have to dip down into the studies of moderate and least suitable design, which includes most of the observational evidence, maximum is a sufficient finding on effectiveness. If those two subsets differ in the conclusion, that's a concern that needs to be raised at the team or task force level about, especially when the stronger body of evidence has the mixed results and in the face of a favorable results from the studies of moderate and least suitability of design. Given that the evidence or information on external validity is an important issue for the target audiences of our work, community guide reviews capture, evaluate, and consider findings on applicability of the evidence. As part of setting up the review, the coordination team identifies important characteristics and makes an initial judgment on the likely generalizability with respect to that factor. Call this an a priori assessment of the importance of the factor, and this helps us, as I'll outline coming up in the next few slides. The assessment of applicability boils down to identifying factors for stratified assessment, comparing the subset findings for studies pooled because they had that factor to the overall findings of the review. We have to be cautious here, as subsets are typically small and studies are likely to have important differences from one another. Strong conclusions from this process are infrequent, but teams do try to answer the following questions. Are these interventions effective across most or all of the examined settings and populations so that the task force can suggest broad applicability? Are there gaps, settings, or populations that were not examined at all or with only a couple of studies? And if so, should differences in impact, such as inconsistent effects or gaps, be identified as task force findings beyond just a statement of fact and the call for additional research? Here's where we find utility in revisiting our initial judgments, especially in the absence of evidence from the review. And this is a guidance table on options for the generation and placement of findings on applicability. Based on how important we thought the factor was in setting up the review, the evidence available on that factor quantified, whether or not the subset results are in line with the overall results, we get a range of options for potential findings regarding that factor and placement of statements in the task force recommendation summary. This slide provides an example of the summation of the process, although it's a fairly boring one. The next slide presents a final piece of the task force evidence assessment table, a set of options for adjusting the strength of evidence or the overall task force conclusion. Findings on applicability, evidence or concerns on potential harms, and recurring quality flaws across the body of evidence, for example, might prompt the task force to downgrade a recommendation. And this set of tables provides guidance on the type of downgrade and the criteria for it. We're going to look at a related and more detailed study in a minute, but this slide summarizes the range of task force systematic review findings for the 234 reviews that are still active on our website. Across all active topic areas, the task force has found just over a third of the reviews to have strong body of evidence of effectiveness. And from that evidence decision table I went over a bit ago, this indicates that the evidence includes and the findings are driven by studies using comparative designs and assessed as the greatest suitability design. Almost a quarter of findings are recommendations based on sufficient evidence of effectiveness, which encompasses reviews in which the evidence of effectiveness is driven by results from observational studies. It also includes some reviews which may otherwise have had a strong body of evidence, but the task force had concerns about issues and prompted a downgrade. 39% of reviews provided the task force with insufficient evidence to determine whether or not the intervention is effective. In our first decade, the primary driver of this finding was lack of evidence, but in our second decade, the more common driver has been inconsistent results across the body of evidence. To date, the task force has only issued 2 recommendations against use of an intervention. First was on the basis of evidence of harms, and the second was a demonstration of effect opposite from the primary outcome on effectiveness. Despite our conceptual foundation and 20 years of experience in the consideration of a relatively broad range of study designs and evidence, we frequently receive complaints that our methods are too restrictive and requests that we consider or expand our focus on practice-based evidence, which can be difficult to define, but it's often described as effectiveness evaluation of a program, service, or policy as it's actually implemented in the field. Definitions may emphasize use of participatory approaches to engage stakeholders, evaluations of ongoing programs and policies, using study designs that place greater emphasis on external validity, use of system science methods to understand context, or practice-based networks to conduct the study. A few years ago, staff at the Community Guide set out to document the inclusion of what we could define broadly as practice-based evidence in systematic reviews produced for what was then 20 Community Guide topic areas. The research goals of our study included developing operational definitions to categorize studies into practice-based or research-based evidence, and then to examine the inclusion of these types of intervention studies across reviews in our topic areas. In addition, the team wanted to characterize and compare the studies in each category by design, intervention type, setting, study location, and quality. The flowchart on the right indicates that the team assembled and evaluated 3,656 studies from 202 intervention reviews across those 20 topic areas. Now, the operational definitions were really basic, and this flowchart identifies the final categorization. Use of randomization in the study design was defined as identifying research-based evidence, and absence of randomization identified practice-based evidence. Research-based evidence was further broken down based on the unit of allocation, whether it be individual, small groups of individuals, or large groups such as worksites or schools. Our conceptual generalizability spectrum is at the bottom, with our 2 primary categories at opposite ends, and group allocated research-based evidence in the along the spectrum in between. The larger the unit of allocation, our perception was the closer that approaches practice-based evidence. I'm going to just point out a couple of things in each of the next 3 slides, starting here with the proportion of evidence that was identified as practice-based or research-based for a selected set of our 20 topic areas. I'm going to start at the bottom. Across all 20 topics, those 3,656 studies, practice-based evidence encompassed 54% of that evidence, and research-based evidence the remainder. Group allocated research-based evidence was 17%. Use or reliance on practice-based evidence was highest in the 10 reviews from alcohol prevention or management, indicating a high proportion of policy type reviews in that topic area, and the smallest incorporation of practice-based evidence was for cancer. The cancer reviews were heavily focused on health system interventions to improve receipt of recommended U.S. preventive services screening procedures. Next slide has findings on the characteristics of the included studies. I'm going to just focus on 4 items. To no surprise, the dominant source of evidence for policy intervention reviews is practice-based evidence. So the somewhat less dominate was use of practice-based evidence for evaluation of intervention set in community settings. And the last issue we'll look at is moderate and least suitability of study designs in community guide work, identify observational evidence, the time series and the before-after studies. And this comprised across all the first 3,000 studies in 202 reviews, 37% of the evidence that was considered. So I'm going to turn now to one fairly unique area of community guide process, which is follow-up systematic reviews on economic evidence for intervention in which the task force has found evidence of effectiveness. Community guide methods for conducting systematic reviews of economic evidence would take a full webinar, and I'm going to get to this in a bit, but we're currently doing a major overhaul of the process right now. I'm going to give you a quick walkthrough following the basic steps of the systematic review outlined on the left. We'll start with prioritization. Task force has always favored restricting economic reviews to projects in which the task force finds evidence of effectiveness and provides a recommendation regarding use. In this setting, economic evidence might be useful to decision makers to choose between effective intervention options and to appreciate the potential startup costs and timing and sources of benefits. Due to staffing limitations, economic projects are now prioritized. We have an economics team. They conduct the reviews, typically making use of both the task force and the coordination team from the effectiveness review. The economic review generally adopts the scope of the effectiveness review. They do limit the studies considered to those conducted in high-income countries, which is something the effectiveness review does as well, so that evidence is relevant to U.S. decision makers. We generally take a societal perspective on costs and benefits, although some reviews may adopt a payer or health system perspective. The economic team conducts a supplementary search for evidence, adding economic terms to the effectiveness review search strategy, and expands the search to include economic relevant databases. The review also includes economic information that's identified by the effectiveness review team, and this is occasionally hidden within an effectiveness paper, typically a data on the costs of the intervention, but it might not get flagged if you were trying to search for it in a database search. The economic abstraction includes intervention components and component costs, health system related expenditures, which might change in response to intervention impact, and outcome data on attributable costs and benefits. Currently, our evaluation of the quality of economic evidence is focused on identifying the important drivers of intervention costs and intervention attributable benefits across the body of evidence, and then rating the completeness of the capture for each study. A good study, for example, will include the most important contributors to costs of the intervention, let's say staffing costs, and the most important contributors to benefits, let's say change in ED visits or hospitalizations or mortality. In synthesizing the results of the review, the economic team attempts to standardize estimates, although this can be a challenge. Estimates from the included studies are categorized and summarized using medians and interquartile intervals for intervention costs, change in system expenditures if that's relevant, and median cost effectiveness estimate. Cost-benefit studies are relatively uncommon, so these are often presented narratively as we're unlikely to have enough for a median. Task force reports the findings of the economic review for each of these categories in a section of their rationale statement. They have the option to add a finding to follow their effectiveness recommendation, and there's criteria for this, although those are now being subject to modification. Currently, it's 2 or more good quality estimates on cost effectiveness using a very conservative threshold for cost effectiveness, or 2 or more good quality benefit to cost estimates. Like I say, the Task Force Economics Methods Committee is currently working on changes for both the quality assessment, to expand the quality assessment of economic evidence, and to essentially adopt a evidence assessment table similar to the one we have for effectiveness review to guide conclusions that would represent findings to accompany the effectiveness recommendation. And they're doing this because we're increasingly encountering more economic evidence, at least in some areas. For example, we did an economic review of team-based care for blood pressure control, and that economic review included 31 studies. I'm going to wrap up with a short list of persistent challenges. Task force members serve for 5 years, and we're in a period of relatively significant turnover right now. New members bring new perspectives on the consideration of observational studies and the meaningfulness of intervention attributable changes or magnitudes of effect. In the last year, we've revisited and revised the evidence assessment table that is used by the task force. We've revised our process steps in the consideration of harms, and then I've already mentioned this overhaul in our methods for conducting economic reviews. Typical database search pull for a broad search for evidence and information on an intervention has increased substantially since I started with the community guide. Citation pulls for a broad search are now frequently 30,000 citations, which can make search screening a labor of love. It's now routine to encounter multiple published systematic reviews related to, but rarely right on the mark of our own research questions. We've added an initial search and screen for review papers and are pilot testing a process for evaluating existing reviews for use by the task force either directly or with a limited amount of work. Finally, where the evidence exists, U.S. Preventive Services Task Force is now crafting recommendations for interventions which might follow up a clinical interaction. And these primary care or primary care referable services include things like exercise programs, which might be found in community settings. The U.S. Preventive Services Task Force recommendations are important as they have coverage consideration implications. It's just an additional challenge for us at the Community Preventive Services to minimize duplication of effort and to avoid the potential that we adopt different findings for similar interventions. With that, I'm going to wrap up and open it up for questions and discussion.
Thank you, Dr. Hopkins, for a terrific webinar. I'm going to start with a question that's related to the material that you presented most recently. Is there a quality assessment or critical appraisal tool that you would recommend for assessing the quality of systematic reviews of economic evaluations?
Of economic evaluations. And I do not know the answer to that. And that would be quite an achievement, I think.
So there's room for the person who raised the question to do a little work and develop something, I suppose. Turning to some more general questions, that was one that was specific to the economic analysis that you just spoke about. But turning to more general things, you often mention the U.S. Preventive Services Task Force, even though your presentation was focused on the Community Preventive Services Task Force. Can you summarize just briefly what the major differences in the methods are that those two groups use in doing their systematic reviews? We understand that they address different kinds of interventions. We know that, but could you briefly summarize the differences in the methods that they use as they approach their reviews?
Yeah, I'll throw out a couple differences. Their process for generating nominations for topics to be looked at prioritization of work and actual conduct of the systematic reviews is very different. They contract out reviews to EPCs. They have a oversight from ARC. Those EPCs frequently use consultants so that to help them set up their intervention reviews and provide subject matter expertise. So they're similar in that regard. In regards to the specific conduct of the review, they are much more restricted in consideration of study designs to the more classic comparative designs. RCTs may be controlled before afters for the effectiveness review. For consideration of harms, it is quite common for their reviews to expand the consideration of study designs to capture things like case reports or other formats by which harms might be identified from the literature. In regards to quality assessment, they have a guidance tool that is study design specific, which is something we should have thought of years ago, and in our upcoming revisits are almost certainly going to adopt as well. In addition, they do provide an overall quality grade or assessment for the studies that are included in their review, and in the narrative portion of their descriptions of the evidence, they will often organize their descriptions of the evidence on effectiveness, identifying studies based on their quality score. They separate internal validity and external validity, so they have a quality grade for both of those two. There are several other issues, but I'll leave it at that.
Yeah, thank you. Those are important distinctions. I know the U.S. Preventive Services Task Force publishes regularly papers describing the methods that they use. Does the Community Preventive Services Task Force do the same thing?
No, and we should.
So that's something that's on perhaps on the list of things to start doing.
Yes, and my guess is that the economics overhaul is going to contribute to a paper that will initiate a set of methods papers.
Yeah. How do the two task forces stay abreast of what each other is working on and coordinate? At one point, I know there was someone who served on both panels, and that was one obvious way, but that's not always possible. So how do you regularly stay in touch with what each other is doing?
So we're liaisons to their meetings. We attend their meetings, and at times when there's the things that we're working on that are very close together, or we have questions about what they're going to work on, which is increasingly becoming an issue because of their aggressive move into primary care referable recommendations. We'll have telephone conference calls with them. For us, it's been routine for us to get one of their retiring members and to join our task force. So we've had two coming to us and one going to them, and that helps keep the lines of communication open. And sitting on our task force, we have somebody who understands the differences between the two groups in terms of decision making and in consideration of evidence.
Yeah, our office is in a very enviable spot because we attend the meetings of both groups, so we stay very much informed with what both panels are doing, and it's important work for each panel addressing different but clearly related issues. The Community Preventive Services Task Force considers cost. I don't think the U.S. Preventive Services Task Force does.
I believe that's correct, and I believe that's specifically not something they look at.
Right.
We consider costs, but it's a separate process from the determination of effectiveness, and it is we provide information that might be useful to decision makers, but there's no our reviews, in contrast to the U.S. Preventive Services Task Force, where coverage consideration is related to the recommendations. Our reviews and recommendations are primarily advice to the field, and we're overjoyed when people make use of them, especially CDC and NIH partners.
One of the interests of my office is in encouraging the institutes and centers at NIH to support research to advance the work of the two task forces. So if we know that one of the task forces has said that, hey, we are lacking evidence on this or that, we may try to stimulate conversations across the campus, or at least in some of the ICs, to try to stimulate additional work that could, over a period of years, eventually address the gaps. Take a few minutes and tell me, as well as the others listening, what kinds of things are missing as you all are reviewing evidence for various topics. Is it evidence of long-term effectiveness? Is it information on cost? What are some of the kinds of things that are commonly missing that you'd really like to have?
So given our interest in information from a study on that could be useful for external validity or applicability, reporting of population characteristics, even at the community level, is extremely useful. So knowing that a study was done in a low-income community is useful for us, and that isn't always reported, although many of the community-based programs will make that effort. In regards to the practice-based evidence, the similar things. The study design might be weaker, but that can be complemented by additional details about the intervention, implementation of the intervention, and the target populations, which would provide evidence that we can make use of. I'd like to call for longer-term studies. I'd like to call for randomized controlled designs in the topics that we look at, but those may not be feasible in some of the topic areas. But we certainly wouldn't be opposed to stronger stronger designs used to evaluate types of interventions that we look at.
Well, certainly our office is all in favor of using the best possible methods to evaluate prevention research, whether it's community-based or something that's done out of primary care. So we would agree with you, and we are regularly encouraging our colleagues around the campus to support that kind of work, as well as longer-term follow-up, which we think is important. One of the points you mentioned in response to an earlier question was that the methods that the two task forces use to select topics are different. Can you remind us, how does the Community Preventive Services Task Force choose the topics that it decides it's going to work on? You showed us a list from, I think, 2015 of topics that you're currently working on, so presumably in about 2020, you'd have a new list.
Yes.
How do you decide what's going to be on it?
So the last time we take public input or nominations, and I believe we had website submissions, although that was quite a challenge. The primary source is we'll typically start with Healthy People 2030, identifying topic areas. And then the task force is going to prioritize topic areas, and so Healthy People 2030 is likely to outline most of the potential topic areas that the task force will consider. Will provide information to accompany what are possible avenues of exploration for topic areas that they might not be familiar with, and then our existing body of work, if it's a topic area that we do already have an existing body of work on, and they can make decisions in whether or not that body of work is adequate, and we should use our limited resources and go into a new topic area, or if that new topic area might not be ready for prime time yet, in that the issues are new, and it's unlikely that there's a body of evidence from a community perspective to inform use in the field.
Does the task force or any other group that you're aware of monitor implementation of interventions that the task force has identified as effective? once the task force makes its recommendation? Is there any kind of a sort of post-recommendation monitoring program?
Not a surveillance system. I think at best we take anecdotal evidence and are fairly aggressive in looking for what we call community guide in action examples where people have used the community guide at the local level to either decide which areas to invest their own limited resources in or partnering efforts. That's about as active a search for uses of the community guide that I'm aware of.
Do you have some examples of how the task force's findings have likely influenced greater or lesser use of a particular prevention program in communities?
It is, I sit in the Oregon Health Department, and much of the chronic disease portion of the Oregon Health Department operates under CDC program support. And for some of the topics like physical activity and tobacco use, but mostly physical activity and asthma, the community guide reviews are often a part of the set of you should examine these and consider these for your program activities based on a CDC support.
How often has the task force had to go back to a recommendation that it's issued and downgrade it from something that you recommend to something that you decide, well, the evidence really isn't sufficient, or maybe you even change the position and say no longer recommend? Does that happen often?
It does not happen often. Older reviews get archived, so they go obsolete, either because the intervention isn't as active an active area of interest, or more commonly because we lack the resources to update some of our original work. I think we've revisited one intervention review, but I think it was going the other way from an insufficient evidence to a conclusion on effectiveness. I am not aware of intervention reviews that we have revisited and downgraded.
Well, that would be a good indication that the judgment that the task force is reaching is sound and based on sufficient evidence, that it doesn't get turned around later. That does happen occasionally with the U.S. Preventive Services Task Force, where new studies come out and they decide that something is maybe the new studies disagree with the existing studies, and so they'll decide, well, there's no longer sufficient evidence. So it does happen there. I know that the community task force issues insufficient evidence statements. Are you often able to turn those around as you have additional information coming out?
Yeah, although, so like in our first decade, most of the insufficient evidence assessments of the task force were based on small numbers of studies, so like 1 and 2 study reviews, and several of those in the initial updates were converted because additional evidence had accumulated. More recently, insufficient evidence is a more common result of a completely mixed body of evidence, which may be saying something in terms of the effectiveness of the intervention approach when the body of evidence does not get clarified over time.
We have a question from someone who works in a local healthcare district as a community advocate, wondering how they can support local intervention projects. What are some ways that they can train themselves to be current in the sorts of activities that the task force is recommending?
Excellent question. And my guess is there's no easy answer. It's in the state of Oregon, it's definitely opportunities are for partnering with the state health department program, which may have funding for specific topic areas, and are frequently looking for for partners to implement programs that they want to promote.
As a methodologist, I was paying particular attention to the kinds of study designs that you were talking about on some of your earlier slides, like 9, 10, 11, in that area. The kinds of designs that you consider and which ones you consider to be more important. I didn't see stepped wedge on the list anywhere. Is that?
I saw your. Didn't you have a webinar on that?
Not long ago. Yes.
So yeah, I'm not aware of that. I've not encountered that yet.
We see certainly applications of that methodology in hospital settings, which may not be as relevant for you, but we also see them in community settings, which would be relevant for you.
Yes,
so
would be relevant to us.
Of course, it's a type of group randomized trial, but a different sort, and one that I think probably has a lot of appeal in communities who don't want to have a control arm.
Yeah.
Can you say more about the trade-offs of the explosion in the literature leading to using existing reviews, and how the weaknesses in detailed information in reviews affects the community guide process?
Yeah, another excellent question. So certainly the presence of existing systematic reviews has to be by us considered seriously as a potential alternative to doing them ourselves if the review's high quality, because just of the length of time it takes to produce a review. In that situation, our current piloting efforts are exploring what the trade-offs are, is the task force willing to make in terms of absence of information. And it's been pretty rocky with our initial reviews, and that they are initially open to considering the review, but as you look under the hood, you become concerned by the kinds of stuff that you're used to seeing, but isn't there, and it's not available in a 4,000 word summary of a systematic review, which is and may not be available in the summary evidence tables for the studies included in the review. Typically, for our pilot programs, it's very common for us in considering a systematic review to determine that the minimum effort is to pull all the intervention reviews, all the studies included in the review, and do additional abstraction, which detracts from the potential utility, although it's still probably a significant time savings. So that issue of the scope of the reviews that we have, that we find not being exactly what the scope or the research questions for our review, that's a big problem for us. So that routinely the reviews that we encounter have just one slightly different scope issue. So we're looking at use of e-health for physical activity in older adults. And it's narrowed to a specific population, the interventions of interest to us, the outcomes of interest to us. But if we were doing our own review, we'd be open to a broader range of study populations. We'd be interested in adults, or maybe so the full range of adults. So those kinds of decisions that have to be made on whether or not to make use of an existing systematic review are routine, in addition to the fact that once you get under the hood, you almost invariably want additional details from the included studies, even in an up-to-date systematic review.
Well, thank you very much, Dr. Hopkins. I'm afraid we've exhausted the hour that we had available to us, but I want to thank you very much for your presentation today, and I'll turn this back to Marie Rienzo.
Thank you, Dr. Murray, and thank you to everyone who participated in today's webinar. On the Mind the Gap website, prevention.nih.gov/mindthegap, you'll find several resources for this talk, including the slides and a list of references. We will also be posting a recording of today's webinar on our website next week. You will receive an email with a link to the recording when it is available. Thank you.